Hi there. Welcome to ComplyPlus Presents. I'm joined again in our studio here in Coventry with Dr. Richard Dune.
Hello,
How's
everyone.
the last couple of weeks been, Richard?
It's been pretty hectic.
Very busy.
We are back to normal now, or whatever normal is supposed to be.
Back in this time zone, at least.
Yeah, in the time zone. And it's a bit of a shock. You get back here into the UK and the weather's changing.
Yeah, literally
Uh,
just as you landed,
just
it
as you
seems.
land, the weather's changing because throughout summer, I was seeing people complaining about the heat waves and all that.
Yeah,
Then as you land, it's a completely different thing altogether. But look, it's good to be back and a bit more settled now in the office. Yeah.
yeah,
How about
excellent.
yourself?
Yeah, been busy
Mm,
holding the fort.
mm,
Yeah, a lot going on. August traditionally is a little bit quieter for us, I
mm,
think, as we touched on last week's episode. But
yeah.
yeah, there's been some interesting things going on within the business, but also within the
Mm.
industry, I think. Yeah.
Yeah,
So
definitely. It's that time of the year where everyone is starting to talk about winter pressure. But then some people in the NHS are saying, "What winter pressure? It's all year
I
pressure
was about
now.
to say
It's
24/7 pressure.
it's
Yeah,
not
yeah,
it's not just winter pressure anymore. It's a continuous
yeah.
pressure. So it's quite interesting, really, with our topic this week. Actually, I think there's a lot to think about.
Yeah,
Yeah.
I was about to
Mm,
say it's quite a fitting
mm,
topic based on, like you say, there is obviously always that surge as the
mm.
weather starts changing.
Yeah.
Pressures on health and social care services do increase.
Yeah.
But yeah, it's a fair argument to say they're always under pressure. So yeah, like I say, today's a bit of a different episode. This is one of two. We are going to be doing another episode on Friday. But today we wanted to get in the studio and talk about the HSJ Patient Safety Congress that Richard attended with some of his colleagues up in Manchester
Yeah.
last week. For it was a 2-day conference. So really, it'd be good to really set the scene. What is the HSJ Patient Conference, Richard?
Mm.
What are some of the themes that get discussed? And maybe just give us a summary of how you found the 2-day event.
Yeah. So the Health Services Journal has been running for many years now. So they do this Patient Safety Congress, which is a conference, annual conference, traditionally in Manchester. Incidentally, it's the last year they're doing it in Manchester. They're
Okay.
moving to Telford, which is a bit easier for me.
How's that? It slows the commute
much
down
much closer,
slightly.
much closer. Yeah. So it's the 18th one that they've done. So as you
Okay.
can imagine, the past 18 years has seen huge changes in the UK. You saw changes of government, from the Labour government, Tony Blair, Gordon Brown, to the Lib Dem Conservative government, the in 2010. Yeah, then the David Cameron government, Theresa May, Boris Johnson, Liz Truss, Rishi
Mhm.
Sunak, and now Keir Starmer, and countless, more than a dozen health secretaries during that time.
Mm.
Right, so it's one of those congresses that I've never attended it. It was my first time actually attending it. I've always followed it. If you subscribe to the Health Service Journal, then you follow it. You know what's going on. But it was good to go there and just sit and watch and listen. So you get leaders, NHS leaders, including NHS England. We had Sir Julian Hartley, the CEO of the Care Quality Commission. We had Dr. Penny Dash, who did the review that declared that CQC was not fit for purpose. You had regional leaders. You
Mm.
had private companies like ourselves. A lot of the bigger companies that are providing software to the NHS. It's geared towards the NHS.
Yeah,
So a
more
lot of
healthcare
yeah,
based.
yeah,
Yeah.
more healthcare based, but particularly more NHS based. But everything that they're discussing affects the whole spectrum of health and care
Will
services.
filter
And,
through.
and,
Yeah.
and I think that's one of the things that I found. Actually, I was even talking to some of the people to say, look, you do realize that for ourselves, for example, we work with smaller companies that are commissioned to provide energy services. And all these things that we are discussing affect them. And they have absolutely no idea about some of the things that you're talking about. So I found it really interesting. Obviously, the whole purpose of this conference is to create a safer, more resilient health and care system.
Yeah.
So you've got even the host, the chair, Shaun Lintern, who's the editor, health editor for the Sunday Times, and he used to work for HSJ as well. He's quite knowledgeable. He's quite knowledgeable. He's been around a long time, and so for me, really, it's one of those conferences where it changes how you view things.
Mm.
because I remember even when I started subscribing to the HSJ, I was doing a master's degree in 2009, 2010, master's in healthcare management, health and social care management, and a lot of the things that I was reading about, um, I could not relate them to practice at the time because my job did not cover some of those things. And now, when you go to this congress and the experience that I've had over the years, the job that I hold now, the different things that I do, things fall into place. And what I realized actually personally is that everything that I've done personally, from my master's and even my PhD, was in decision support systems. How do you evaluate these decision support systems? It's all around patient safety, actually. When you think about it, the central theme is patient safety. And even what we do as a business to help organizations with governance, with compliance, with workforce development, is all around the safety of service users and building a culture where people learn from mistakes, whether it's their mistakes within their organizations or mistakes from somewhere else. But then how do you put it into policy and how do you put it into practice? So, yeah, I mean, there were more than 1,000 delegates over the 2 days. It's a
Mm.
huge
Yeah.
number. Even when you're trying to go for lunch, the queues for lunch are absolutely
Yeah.
ridiculous. And
Yeah.
you're seeing people that you normally see on TV standing next to you on the queue. So I was a bit starstruck, a few times.
Mm.
But there's a strong emphasis on culture and leadership because you can't talk about patient safety without good leadership,
Mm.
without a culture where people feel that they can come forward. Then the duty of candor. If I make a mistake, I should be able to come forward and
Mm.
own up, knowing that we're using it as a learning opportunity rather than blame.
Blame. Yeah.
Yeah. And then recurring themes, you asked about recurring themes. The biggest one this year, and you felt it throughout every single conversation because there were several breakout conversations, was workforce well-being. You can't talk about patient safety without looking after the staff, right? I can go into that a little bit more detail, but otherwise, workforce well-being has to be built into the governance framework, including care quality commission as well. How they do their inspections, they need to actually see that organizations are actively promoting the well-being of their staff. And fatigue was another issue that was discussed, and we can talk about that a little bit more. And those maternity services have been in trouble. So Nottinghamshire were there. Their leaders were there talking about the challenges that they have had, how they've worked with NHS England, how they've worked with CQC and healthcare investigators to, bring closure to many families who lost their babies in that hospital. And yes, it's scandal. It's a big scandal. But actually, what do you do about it? You learn, and then you start reversing that
Yeah.
by actioning, those things that people expect you to do. Patient safety incident response framework. We've talked about that quite a bit as well before. I got to understand really how NHS trusts are implementing it and some of the gains that they've had so far. Another thing was Martha's Law. We know that it's now active, and it's something that we need to talk about a little bit more, in the coming weeks. And many people, sharing their experiences with patients or people who lost their loved ones, sharing their experiences of losing their loved ones or their loved ones not being looked after as they should in the health service, and how that experience has made them feel. But their campaigns also, how they've helped to change things, right? And broadly, it's about balancing actually things to sort of say, look, we got a lot of practical case studies, innovation spotlights. There's a lot of good things happening in the NHS and real patient testimonies as well, staff and leaders as well who are changing the landscape. So for me, actually, it was very much eye opening, and you get the strong sense of purpose on the back of it. I know some of these sort of meetings and conferences, it's sometimes it's just talking shop, isn't it? Where people talk and nothing happens. But I got a sense that people are serious. The fact that NHS England has been disbanded, CQC was in trouble, Ofsted was in trouble. A lot of these big organizations actually, and then there's an acceptance that look, we need to change from the top, and also support people that are on the front line. So that was my reflection overall.
Mm.
Yeah. So, but and then I'm really keen to talk more about some of the lessons and interact with some of the people that we met and work together really with people, whether they're in the NHS, then private sector, then care services. There's a lot for everyone to learn from this.
Mm.
Yeah.
Excellent. Yeah, we're going to go through in some of the different segments later on, specific themes, that maybe
Mm.
that reflection, as you were saying, what did you learn? What did you take away? What has it made you think about
Yeah.
moving forward as someone who works, someone who works in this sector
Mm.
and still cares passionately about it as being an ex-professional
Yeah.
yourself. Um, Obviously, there is some stuff on your LinkedIn about how the days have gone as well. So do check out Richard's LinkedIn profile if you want to see some more insights on that side. But one area I wanted to go through, because we have talked about we obviously talk about compliance a lot, being a
Mm.
compliance solutions provider, but we always talk about strong leadership and a
Mm.
good culture
Yeah.
within workforces.
Mm.
Compliance isn't just ticking boxes. I don't know how many times we say that
Yeah.
every week, whether it's to a client, whether it's on this platform, whether it's on our social media channels. So, what did you hear in that segment that most resonated with you? And did you learn anything new or think about culture and leadership differently post attending the event?
Mm. What I saw and heard was that I think the landscape is shifting. There was a time
Mm,
where, would hear about culture, about good leadership,
mm.
workforce planning and all
Yeah,
that. And people just say it
it's almost
and
just saying the right thing.
yes, yes. But there were few people actually that really stood out.
Hmm.
Right. One of them was in the plenary session at the beginning on day one, and Professor Nicola Granger.
Okay.
She's the head of the Royal College of Nursing. She didn't pull any punches. She went in there to fight for nurses, to say a lot of these conversations that tend to happen, nurses are excluded, right? Nurses are excluded from the top conversations, and yet they make up the bulk of the workforce together with allied health professionals and healthcare assistants. They're the ones that are there with the patients every single day.
Front line, yeah.
Every single day, the doctor will come in for a ward round or they'll go to theatre, but the nurses and the allied health workers and the healthcare assistants are there with the patients every single day, and yet they are not properly represented. Yes, numbers may seem like they're improving, the number of nurses hired, but the large majority of people living in the NHS actually are very experienced senior nurses. So you now have this huge vacuum where you have newly qualified nurses coming in and also nurses that are coming in from other countries. No disrespect. Yes, they are trained nurses, but they are still to learn, yet to learn how to nurse in the NHS,
Yeah,
right?
exactly.
So,
Yeah.
so very
Very
passionate
different.
about that to say nurses need more support
Yeah.
and also education and professional development, not just mandatory training, because from her surveys, nurses are only getting mandatory training, which is not enough.
No, because that's
E-
more subject based, isn't it?
Exactly.
It doesn't give you the exposure of
Exa-
other things of
exactly.
living here in the UK.
Exactly.
Yeah.
So, from a workforce perspective, although doctors and other healthcare professionals do have the same challenges, doctors have been on strike a lot, and
Yes. Yeah.
and even Jeremy Hunt in his session as well did talk about that. But so there is that element to say, look, over the 2 days, and it was said quite a few times actually that all the solutions that we need are here. Because you've got CQC, you've got NHS England, NHS Trust, you've got nurse leaders, medical leaders, ambulance services, everyone is there. So why are we not changing? So it's about
Mm,
culture. So say, look, how are we going to fix this?
yeah.
Right? And how are we going to ensure that everyone's voice is heard, including the patient, including their loved ones as well, because there were patient representatives as well, and people that have suffered pain, and harm in health services, people that have lost their loved ones. So nobody's coming to save us. We need to sort this out
Yeah. Yeah.
collectively. Culture comes from within the teams. You don't impose from NHS England. You don't impose it from government. You empower organizations. One particular person is always Kelly McGovern. She's the chief nursing officer in West Hertfordshire. Really passionate. She's saying you can't expect staff to give their best if they're not cared for. So one of the things just she does is go onto the wards every week. She spends so much time on the wards helping out, doing what needs to be done. She was jokingly saying she doesn't wear high heels, she wears trainers. And she was wearing trainers even on stage to say, because I can't go and work on the wards if I'm required to. So people leading actually from the front, doing the things that they are expecting people to do
Yeah.
themselves. It's quite passionate about that. Then Charlie Massey as well from GMC talked about workforce well-being as inseparable from patient safety. And that's part of the supervision for doctors now to sort of say, look, as doctors get trained and qualify, and then their supervision as well in practice to keep reinforcing the need for workforce well-being. Look after your staff so that they can look after the patients. Because from their perspective as well, a lot of the times, even from nursing perspectives, the vast amount of time actually, patients in the NHS are looked after by the most junior people. So junior nurses, band fives, with one or two band sixes, but in the evenings and weekends, mostly band fives, and evenings and weekends, mostly very junior doctors, right? So there is that challenge to sort of say, look, how are we going to get the best out of this situation, right? And patients benefit. There's also the issue of psychological safety. We heard from quite a few people from that side of things, psychological safety for patients and families
Mm.
after harm is done, psychological safety for staff as well to be able to speak up,
It's
whistleblowing
both
without
sides.
worrying. And fatigue. This was quite interesting. I think it was Nancy Redfern. She was talking about fatigue needing to be treated uh, as one of those risks that should be on the risk register.
Yeah, yeah. It does make sense when you think about it. Yeah.
Because you and I have flown around the world, right? When you
Mm.
fly, whichever airline you fly with, as you get off the plane, the staff are also getting off.
Mm.
Then they'll go and rest and sleep before their next shift.
Before their next, yeah, night or whatever. Yeah.
Yeah,
Yeah.
I worked in the NHS,
Mm.
and of course, there were European regulations in the end, sort of specifying how much time you have between shifts. But you're constantly moving from night shifts to day shifts to long shifts, weekend shifts, and
Those transitions are
it's
hard. Mm.
really really difficult.
Yeah.
And so fatigue actually, you wouldn't want an airline pilot who's fatigued to fly the plane.
No, yeah, it's definitely not. So yeah, why
Yeah,
would you want someone looking after your
yeah.
health? Yeah.
Yeah. So
Um,
where would you want somebody hasn't had much sleep, who hasn't had much rest, looking after you? Somebody who's working under pressure, somebody who's not happy with the working conditions. So I was sitting there scribbling notes away and thinking, God, that I've never thought about it actually this way. When you describe it like that, we almost look like fools. We don't know what we're doing, right?
mm.
And there's a perma crisis as well. So there was this description of a perma crisis. We are joking about, winter pressure. People were saying, "Oh, winter pressure never left. We are constantly in winter pressure now. So there's this continuous crisis, and it demands that we work collaboratively. We work together, and not competition. Because I think sometimes because of the targets and even the rate,
The league table
the
now.
league
Yeah.
table now, there's competition again.
Mm.
Is it
Yeah.
healthy to focus on those numbers that can then demotivate staff
Yeah.
and patients as well?
But also
Because
patients in the regions. Yeah.
look at Coventry and Warwickshire. Almost all our hospitals are in the bottom.
We're struggling, let's say,
Yeah,
yeah, from a league table perspective. Yeah.
how confident would you feel if I was looking at the league tables? I'll probably not want to go to the hospital. I would probably want to go to somewhere else. Birmingham is not doing great either, right?
Mm.
So I think policymakers, and in particular the government in this case now, because government is taking direct control of the NHS, they need to think about things very carefully because before they implement a lot of these targets and ratings and rankings. What is the impact actually on patients? What is the impact on people delivering care as well? Right? Because
Mm.
if they're constantly battered in the news every day, even we were talking about, we were looking at social media coverage of the hospitals in Warwickshire. It's almost like it's a comedy festival, really, of how
Mm.
badly things are done. And think, but hang on, I used to work in these hospitals. I know people that are still working in this hospital. I know they give their 100%,
Mm.
and no amount of rankings will be able to reflect what they're doing every day,
Mm.
right? So I think there's also issue when you look at patient safety incident framework. Anyway, people are now looking more at systemic issues rather than blaming people. That blame culture that used to be the case. You're now looking at the wider system, not just the processes. You're looking at the wider system because sometimes actually one part of the hospital can be doing very well, and another part doing not so well. But actually, how do you standardize those systems so that you get better reflection of performance and also investigate where you need to investigate so that we learn and hopefully never happens again?
Mm.
Yeah.
Excellent, excellent.
Mm.
Um, so yeah, I think some very interesting takeaways there, and hopefully even for some of our listeners to start thinking about in their organisations, whether
Mm.
a member of staff, but also someone in a leadership or senior role within that business. I think there's some really interesting themes that could be took away there and thought about in terms of how you could implement some of these ideas. I think really to improve things, but also to
Mm.
things to consider because I think some of the things you've touched on there
Mm.
may go unnoticed more. Because there's budget pressure, because
Yeah.
there's time pressure. Do people really care?
Mm.
Do people really care about some of these things? They're probably some of the terms bandied around. So, yeah, thank you very much for that, Richard. Another area our team asked me to go into, based on your debrief with them, was governance and
Mm.
compliance and risk. Again, something that we talk about a lot on this podcast for obvious reasons. What are some of the lessons here for us and for some of the providers we work with, more importantly, to
Mm.
to think about? And were there any new things that, again, from a personal perspective, you learned, or a new twist maybe on something that you hadn't thought
Mm.
about previously?
Yeah. One of the things that we need to do on the back of this is to say, look, people that are using ComplyPlus in some of our systems that we've built, for example, how can we embed some of these reflections and lessons into usable tools that they can
Yes.
actually use in practice?
Yeah.
Remember, I was saying that this is geared towards the NHS. And sadly, a lot of the conversations, whenever you talk to, by the way, there was not a single government official there.
Present across 2 days.
No, 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 no. We had Jeremy Hunt, the former health secretary,
Yeah.
but none of the ministers,
None
none
of
of
the
the
current
the
people in
current. Yeah,
post.
yeah, yeah. Of course, you had people from NHS England. I accept
Yeah.
that, but yeah. So um, governance systems. When you talk about governance systems, we need to put some tools there ourselves that connect staff well-being with patient safety outcomes. Or if it's a care home or domiciliary care company, actually, what are the service user outcomes, and how can you link them with staff well-being?
Yeah.
I think that's going to be really crucial,
Yeah.
right? Because we look at CQC reports for a living, and it's almost you sort of think, how did we not connect that before? So
Yeah.
we need to sort that out
Yeah.
ourselves. Then the other part is also the safety dashboards. I think we need to revisit our dashboards again to sort of say, look, when you're looking at uh, in organization is doing audits, for example, how do they get a dashboard that shows them the safety and well-being side of things, staff well-being and safety side of things. Then our training modules as well. I know we do focus a lot on clinical skills, and obviously a lot of organizations coming to us want mandatory training and statutory training. But how can you also add the psychological safety elements into statutory and mandatory training? We're talking about our colleague Helen Evers to say what she's doing actually. A lot of her training is really brilliant, but actually, unless you frame it in a CQC framework, no one is interested.
Or it has to be compulsory or whatever. Yeah.
Yeah,
Yeah.
if
Yeah.
it's part of compulsory training, I bet you people will be queuing up every single day,
Yeah.
right? But because she's doing it to say, look, staff will be able to do this, um, people are not bothered because it
No.
doesn't help them tick any of the boxes,
Yeah.
right? Then speaking up as well, encouraging people to speak up more, adding that to health and safety training, safeguarding training, and making sure that it's in policies and procedures. So continuing professional development should act as a vehicle for culture change, not just skills development. And I think, and I think there's a focus, too much focus on the statutory and mandatory staff and the clinical skills development. You need to build in culture change as well as part of the training. So that takes us to the patient safety incident response framework, which it was part of the core discussion to sort of say, look, it's showing maturity now. There's a lot of progress that has been made since it was implemented, but there are also issues around inconsistencies in its implementation. And even when we have looked at NHS trusts that are failing, you look at their CQC reports, you look at their patient safety data, it's linked directly with the same issues that we've been discussing all along, right? So there's also an issue around cost of harm, for example.
Yep.
It's, negligence payouts over £2 billion.
Okay.
Yeah, that's a
It's
huge amount.
quite a high amount of money. Yeah.
Yeah, it is. But obviously, if people have been wrongly treated, people have been harmed, they've got right to seek recourse,
Yeah. Yeah. Of course. Yeah.
including financial payments.
Mm.
But then, how do you balance between justice for harmed patients and their loved ones, and the resource for future care? Because this money has to come from somewhere. This
Yeah.
money,
Someone has to pay for it, don't they? Yeah.
exactly. And
Although
for a
they're entitled to it.
taxpayer
Yeah.
funded system, we're paying for it.
Yeah.
Right. So I think these are some of the conversations, our approach to investigations. And I'm pleased this was also discussed. We need to change our approach to ensure that we look at restorative justice, because speaker after speaker, the family members were saying, and people who ended up suing the NHS were saying, the experience itself of experiencing poor care or death, loss, actually trying to fight for justice was a much worse experience
Mm.
than the initial
Than
harm.
the actual. Yeah.
And I found that really shocking. So I think our approach to how we investigate is to be compassionate, because quite often people that are complaining or raising concerns are ignored. They're
Yes.
not taken seriously, and when they are brought in to explain their situation, sometimes they feel that it's being done just to tick a box to say, yes, we talked to them. So I found that quite shocking, but at the same
Yeah.
time, I was hopeful that the experiences of these people do not go in vain.
Yeah, providers probably,
Mm,
like you say, they need
mm,
to be a bit more receptive to some of these negative things, whether it's
mm.
feedback or whether it's an
Yeah,
official or formal complaint. Yeah,
yeah,
I think that's a fair
yeah.
comment.
Because a lot of people, to start with, my experience with complaints is that people don't want to complain in the first instance.
No, I think
Yeah,
90%
yeah.
of people don't want to actually complain
They're
because
raising a concern. Yeah.
even the
Mm,
example you've give there
mm,
of the family speaker at the event,
mm.
it's that is also quite painful to revisit
Yeah,
what's actually
yeah,
happened, isn't it? Yeah,
yeah. But they're doing it because they don't want it to happen to
to someone
somebody
else.
else.
Yeah,
Honestly, 3, 4 people lost babies, and they think, God, they're brave
yeah,
to stand in front of 1,000 people
at a
and
big
speak about
conference.
the
Yeah.
loss, one conference after another, one conference after
Mm.
another. And then for them, actually, the worst thing is it still happens, it continues to happen.
Mm.
So lessons learned, what are we doing about it? That is the key. So there was also a lot of discussion around freedom to speak up, although we now have guardians. It's statutory requirement now, but actually there is progress, but there's still a lot of barriers. People still worry about speaking up. People don't feel that they are protected adequately if they do speak up, and culture change remains a key issue. So from our perspective, if I go back again, because I kept thinking, all these things that I'm hearing here, how can we put it into practice? For example, the patient safety incident response framework, how can you implement it in a smaller organization that doesn't have a governance department, it doesn't have a chief medical officer,
Yeah.
chief nursing officer, so what sort of tools can be developed actually to track incidents properly, learn from them and report from them? You and I went to a few clients over the years who are running quite respectable businesses. They're well funded, but they're still filling in their incidence form on piece of paper that then go to
Yeah.
a manager who then does some investigation. Nobody really monitors it.
Yeah.
Never gets to the board unless it's a big problem,
Yeah.
and that needs to change.
Yeah.
So for me, actually, the challenge from that perspective, and for you as well as a developer of software for compliance, what shall we do to make this better? So
Definitely.
because
Yeah.
actually, when you see the data, if you're running the business, if you're the registered manager or you're the director or owner of a business, it makes you change
Yeah.
your perspectives.
Yeah.
If
Or
you
at least
see
act on it. Yeah.
exactly, if you see what your business is doing or your organization is doing, and how people are who are receiving that care feel about what is their experience of working with your organization, that should help you reflect and then change how the organization perceives patient safety.
Yeah.
Mm.
No,
Yeah,
definitely.
yeah. So dashboards again, we need to look at how we put up dashboards that are reflective of the national conversations,
Mm.
right? Because even Care Quality Commission, I think they're going to radically change, because now the fact that they've got chief inspectors for healthcare, for hospitals, chief inspector for mental health, chief inspector for primary care. This job used to be done by one person, and now you have chief inspectors who specializing in different areas. So I think things are going to get better in that sense, because there's a lot more focus. So another area we need to sort out as well is to work with organizations so that they understand the need to customize their policies and procedures for investigations and whistleblowing, and how they look at safety of service users, rather than just ticking boxes again. How do we change the culture, sector, subsector by subsector? If it's domiciliary care, for example, if it's care homes, if it's independent, smaller healthcare clinics in the community, what do they need to do? And as well as in the NHS as well. Although the NHS does have the capacity and budgets to hire the right people and also get the right software in. But actually, a lot of it, somebody said, we have this problem in the NHS where we have a lot of data, but very little information.
Mm.
And that's quite a
It's an interesting comment. Yeah.
Yeah, it is. It's quite an interesting comment, and that's my experience as well. Even on last time I was working in the NHS, we're doing research, looking at decision support systems. We collect a lot of data. Every set of observations that we get, every decision that is made.
Mm.
How are we using that data actually to inform future practice? That is the challenge that we face from a governance perspective, looking at compliance and risk. How do we connect all these things and then build them on culture and workforce development that we were talking about earlier?
Yeah.
Yeah.
And improve processes. Yeah.
Yeah.
Okay, excellent. I think again some very useful insights there. Want to go on to maybe a bit more of an exciting
Mm,
part of the conference now, where we're looking at more futuristic
mm,
and modern day things that are coming in. Obviously, the big one that everyone is talking about across the world,
mm,
even the biggest politicians in the world, and that's AI. Um, there was a lot of discussions across the 2-day event
mm,
on innovation, AI, digital tools.
mm,
What were your takeaways from those sessions? Because I know you've been very pro AI, and
mm.
even as a business, we've spent a lot of 2025, sorry, looking at AI solutions for our business, but also how we can empower them for our clients as well.
So it's interesting. One of the speakers was a patient safety campaigner. So he came in as a patient expert, although he works for NHS England as well. His name is John O'Broad. He says, stop talking about AI.
Yeah, it is getting a bit repetitive, I
Yeah,
must admit.
stop talking about AI. It's not the only solution
Yeah,
to the problems that we're
to our
facing
problems.
in
Yeah,
health and care systems. There's so many other technological solutions. AI has been around for a long time.
it has. Yeah.
AI is not ChatGPT,
Mm.
right? Even for our business, we've been
Mm.
using AI tools since 2012,
Oh
2014,
yeah, at least 10 years
thereabouts.
now. Yeah.
Over 10 years, right? But obviously now it's part of the mainstream.
Yes, it's very prevalent everywhere, isn't
It's
it?
everywhere. And there were quite a lot of organizations, a lot of our bigger competitors, if I may say, were there. And I did get a chance to talk to them. I sat in some of their sessions as well, because they had these innovation spotlights where you could just go and sit and interact with them. Um, they get it as well. To sort of say, look, you know, there are a lot of AI solutions, but AI, it's just a solution that helps us to co-pilot, just like you're never going to remove pilots from the cockpit.
Yeah, exactly. Yeah, yeah.
Yes, you can automate a lot of things, but it's about identifying which bits of service provision and processes that you can automate, and which bits need to still have human decision makers, and also, you know, how do you get to test the systems without AI, for example? Because one of the things, even for me, when I was doing my research in these systems more than 10 years ago, I finished in 2015. So from 2011 to 2015, one of the issues was de-skilling staff. To say some of the tools that were used then, the early warning systems, the national early warning systems, news too.
Yes.
Uh, People were using them without thinking about how they would view the patient without the tool. And part of it, actually, over the years, part of the solution has been to say, look, why don't we do tests where we remove the tool and we get humans to make that decision by themselves?
Just to see as a little social experiment
Yeah, it's an
in many
audit.
ways.
It's an
Yeah, yeah,
audit, isn't
yeah,
it?
yeah.
Because you can't let people that are highly skilled use tools and then get so dependent on those tools,
They don't know what they're doing
they
without
don't know
them.
what they're doing without them,
Yes.
right? And that's really crucial from a workforce development perspective.
There's a very good point about AI
Mm.
in general, actually, isn't it?
Oh yes, yeah.
Yeah. So, and especially
Mm.
in our sector, something to really think about. Yeah.
Yeah, because AI, they still hallucinate. You know,
Yeah.
if you don't know what you're doing, it gives you wrong information, and you may not even know that it's giving you wrong information.
Because you're so reliant on
You're
it.
so
Yeah.
reliant on it. So you still need human judgment. You can never replace nurses and doctors,
It
allied
should
health workers.
um,
Mm.
coincide what people are doing
It's a
to help them.
co-pilot.
But
It's a
yes.
co-pilot.
Yeah.
It's not. It's not taking over from you. It's helping you.
Mm.
Maybe some of those mundane things that need to be done in large
Yeah.
batches, for example, then it can do
Efficiencies.
that. Yeah.
Yeah.
So there's an issue around organizations. AI strategies. What is your AI strategy and readiness as well as an organization? Are you ready to adopt AI?
Yeah.
And what things do you need to do to be ready? Right? Are your people ready as well? What sort of training and support are you going to give to staff? What are patients going to be confident with these systems as well,
Mm.
right? Because if I'm using it on my phone, and then the doctor is also using it on their phone, even data, where does the data go? What,
Yeah.
what sort of guardrails do you have?
There
Yeah.
is so many
Mm,
considerations. I think
mm,
even the five or six you've sort of listed there.
mm,
A lot of time really is needed to
mm.
plan and
Yes.
prepare accordingly. Yeah,
Yes. Then you stagger as well the implementation. Maybe
yeah.
you
You
do,
can't do it all at once. Yeah,
modular. Yeah, you do
yeah,
it in a modular way. So applications and practice. I was really surprised because, like I was saying, my research, a lot of my research was in decision support systems, and I was looking at the early warning scores, national early warning scores, pediatric early warning scores. I didn't realize that up to now there are still dozens of different early warning scores in pediatrics. So there's a lot of effort now to standardize these early warning scores so that sometimes within the same trust, people are using different scores,
mm,
right? We've been in adult settings, we've been using standardized scores for more than a decade now. So yeah, but there are a lot of really encouraging numbers that are coming, showing that the standardization of the pediatric early warning scores, fatigue monitoring as well for staff in pediatrics. So because I've never worked in pediatrics, and it was quite interesting. I forced myself to go into two sessions for pediatric early warning scores, and just hearing people from maternity services, things that I don't know about. But I learned quite a lot that we can also apply,
yeah.
because some of the challenges
Certainly.
are, they affect all the other subsectors as well.
Yeah,
So yeah, I found that quite interesting. So from our perspective as well, if we go back to us as a business, is to say, look, the predictive insights as well for organizations on dashboards. How do they deal with near misses and safety trends? So near misses actually need to be recorded and they show on a dashboard somewhere, because quite often actually near misses are ignored, and then
and then it eventually happens. Yeah, yeah,
exactly.
yeah.
Then we have a big scandal on our hands.
Mm.
So there's also the ethical side of AI, which needs to be considered. There's the need to integrate AI into education, training, and governance as well.
Yes.
And even Dr. Aidan Fowler, who was working for NHS England, he did talk about that, to say it's not so easy to regulate technology that keeps changing. Because AI changes so much, it learns and then it keeps adapting. So how do you regulate something that there's so many moving parts? And that's quite interesting actually to say we could try to regulate AI, but actually because of its nature, where it's learning and self-adapting, how do you regulate it properly?
Yes, because
Mm.
there's updates constantly, isn't there?
Yeah. So part of that is self-regulation as well, to say what guardrails do organizations put in place.
Yeah,
But also Care Quality Commission inspectors now need education as well on how they regulate
yeah,
AI, how they regulate these decision support systems.
yeah,
And it's part of the challenge really for CQC to hire the right people, to train them properly, and to keep continually learning and adapting the inspections system as well. So we need smarter connections as well between compliance, governance, and workforce well-being. And I think for me that is the biggest lesson. Never mind AI, or the other stuff. Actually, it's look, which forms of innovations do we need, including AI, and how are we going to um, adopt them, implement them, and also evaluate their effectiveness? Because once we get them in, sometimes we think, oh, yeah, we've got it in and it's working, but actually, how effective is it? So
yeah.
again, going back to those audits and monitoring outcomes.
Yeah,
Yeah,
I think just assuming that AI,
yeah,
because everyone else in other sectors are doing it and everyone's talking about we have to have it, like you say, if
mm,
it's not effective or it's not actually giving you the outcomes you want, then
mm,
what's the point, like you say? So yeah, I think that's very, very interesting. There's a lot of AI noise everywhere you look at the moment, but
yeah,
err on the side of caution.
definitely. Yeah.
And I think planning, from what you're saying there, there's a lot of things for organizations to consider
Mm,
before just signing up or signing up to these different
yeah.
softwares that are coming out here, there, and everywhere. Um, so yeah, if we look at closing reflections, I know one of the things you mentioned in the debrief with the team was there was a really interesting conversation between Shaun Lintern and Jeremy
Mm,
Hunt.
mm,
A conversation that I think resonated with you probably as one of the most important parts of the 2 day conference.
mm,
So what stood out especially from that conversation that
mm.
you observed?
Yeah. So obviously we need to, a lot of people in healthcare would know Jeremy Hunt
Yes.
because he was one of those, I think he's the longest serving health secretary ever.
Mm,
Right. So he was health secretary at a time when the coalition government of conservatives and liberal democrats was making some really drastic cuts to services, including NHS services, because they came in after the crash, 2008 crash, and the government borrowing was so high. And then he came in to continue that,
mm,
that work, and fought with doctors and other organizations to justify why the government was making such huge cuts. So, and it became very unpopular as well in certain quarters, and even within the room. I think there was one or two heckles as he
mm,
was speaking. And I mean, he's a politician, seasoned politician, he can handle that. But what was interesting for me was this is somebody that I've seen from afar. When I was doing my research and you're writing assignments and you're presenting and things like that, you read some of the things about some of the things that he is doing. So to hear from him explaining firsthand many years later was quite interesting.
mm,
Right. So he did acknowledge some of his achievements, like neonatal mortality reduction, and controversially balancing the books, right? Because people
mm,
would see it differently. But also his regrets, for example, how he handled the disputes with the so-called junior doctors. And, one of his regrets was saying, what I realized afterwards was that fighting with the junior doctors was not, yes, it needed to be done to sort of correct that pay structure and the working conditions, but I should have started with the senior doctors instead.
okay. Mm,
But I ran out of political capital. I didn't have the political capital to start a fight with them,
no.
right? But one of the regrets as well was around sticking with national targets. To say, I felt that afterwards, when I looked at it, patients became numbers, we shouldn't have focused that much on targets. And incidentally, he went on to form, is the chair of the all party parliamentary group on patient safety, and also a charity that looks at patient safety as well. So I think from my perspective, I'm not judging him on a personal level, but it felt like he was quite genuine. And for somebody he doesn't need to be involved in healthcare anymore,
Anymore, yeah,
right? But
exactly.
he's still very much involved in the conversations. And if you follow him, actually, you realize actually that he still seems quite passionate about
Mm.
the service. And there were a lot of questions around workforce investment, versus reform. Obviously, you can only invest in the staff if the funds are available. But obviously, if you're reforming and cutting and trying to balance books, then it doesn't quite add up in the
Mm.
end. And every government will claim that they hired so many nurses, so many doctors. There's always numbers. Numbers don't matter. It's how people feel when they're working in the service. And that's why some of the people were I think somebody shouted that there's no evidence for what he was explaining, and
Mm.
think, okay, people are still quite bitter. But it's good to have, because some people just walk away and you never know what they were thinking. He's written books about this. So I thought that was quite interesting. And I've not read these books. I'm going to buy the books actually and read them, try to understand actually people that are making decisions that affect all of us. What's guiding those decisions?
Mm.
you know. So he emphasized as well around safety needing to be embedded in national strategy and not being treated as an add-on, because even by his own admission, they didn't look at it so much,
No,
because he was even arguing that you know the argument that there's a difference between quality and safety, is pretty much one and the same thing. If you do one, then the other,
then the follows, yeah.
but obviously, if you look at it from a practical perspective, unless you define it, unless you budget for it, then it's not going to be done.
No.
It's not going to be done, and people don't have the incentive to do it. So you can't have quality and patient safety bundled together. Yes, the safety forms part of the quality framework. I get it, but actually, I think the emphasis on patient safety, when you listen to mothers and fathers who have lost babies, when you listen to pregnant women who were treated badly, and all their stories there
Mm.
behind yes, behind those people, there are stories, but actually, these are experiences that they have had. And it's not just another story.
Mm.
And then sometimes we treat it as a story to say, oh, like Nottinghamshire, how many families suffered. We don't even know. We don't even know their stories. We only know numbers to say, oh, so many dozens
So
of
many
babies were
babies
affected.
died or whatever, yeah, yeah.
Exactly. So I think it was quite interesting, because you sit there and you think the room goes completely quiet, and these two people are talking, and many people are thinking, does this add up? Does this make sense? Some of it you agree with it. Some of it you sort of think, yeah, we still have a long way to go. And I think that disconnect between what politicians are thinking and the decisions that they're making for us, and
Mm.
what we are actually experiencing in practice. I'm one of those people that left the NHS, tried to go back, and then thought, no, this is not for me, and I left. And I've been out now nearly 10 years.
Yeah.
I do have regrets. I wish I was still there doing some of the things that
You
some of my
enjoy.
colleagues are
Yeah, yeah,
doing right
yeah.
now, things that I enjoyed, but I left. I'm one of those people that left, and I have my reasons for that. And then when you sit there and you have all these different people talking about the service and their impression of the service, and I think, okay, we have a long way to go.
Mm.
But actually, I think we need to give everyone benefit of the doubt and hope that they didn't just show up to say things.
Yeah.
Hopefully you see meaningful change.
Yeah,
Yeah,
on the back of this, and
yeah,
obviously because it's an annual thing as well, you hope that you
yeah,
you can see that progress between even the conferences. I know
yeah,
a lot of things have to happen in between
yeah,
just people standing on a stage and talking or
yeah,
a conversation, but yeah,
yeah.
definitely.
And one of the things actually, hopefully in within the next year until the next Congress, you will know what the disbanded NHS England looks like
Looks like, yeah,
in the
yeah, yeah,
Department of Health and Social Care.
yeah,
Will know what, say, Gillian Hartley and his team at the Care Quality Commission have done
Yeah,
to
yeah.
improve,
What direction they're going in,
to
yeah.
improve how CQC works with
Mm.
providers, because they have to work collaboratively. And the thing is, they had a good start. To be fair, the team at CQC have had a good start. They've got good leadership, and a lot of things actually seem to be going in the right direction. But again, we want,
Sample size will be 12 months bigger
yeah,
by
yeah,
then to have a
yes. In
look at,
12
yeah.
months' time, it'll be interesting to see where we are. And I worry as well, because we've gone through many different types of healthcare systems, and I've traveled around the world as well, and then learned about different healthcare
Yeah.
systems. I think there's a need for a level of decentralization for decision making. Allowing NHS trusts to make decisions for their local communities.
Mm.
But again, then if you have rankings, if you have targets and all that, you're still controlling the agenda nationally. So it's a pseudo decentralization in a
Mm.
way, where there's an impression that yeah, we can make decisions about how we deliver the services, but actually somebody's controlling it from the back. Because then the accountability is given to those people running local organizations. Um, but actually, do they have the power to
To
actually?
actually, yeah, enforce change
Mm,
or make the big decisions that need to be made, yeah.
exactly. But there were some people, like I mentioned, Kelly McGovern, quite interesting, and even from an academic perspective, we did have a chat. Did say to look some of the work that we're doing with Professor Julius Mngwagwa at UCL, to say we could look at some of these trusts, actually NHS trusts, to see what can be learned from his culture. Is really, for her, it's all about culture. It's all about standing up for nurses and allied health workers, and ensuring that their voice is heard, ensuring that, she was talking about removing patients from the corridor. I've never heard anyone come forward and say we don't have patients on the corridors anymore. She was even saying, when she became chief nurse, she was walking around, and people were happy that finally they've put plugs on the corridors, so
Mm.
they can now give better patient care on the corridors because they've got plugs on the
They've got
anything.
plugs.
And I thought to myself, God, if you put plugs on the corridor, then you're saying we've given up.
Yeah, that sounds like last
Yeah.
resort sort
Yeah,
of,
we've given up. Now we're going to put trolleys on the corridor, and we're going to put pumps, and we're going to plug them onto the wall so
yeah.
that we can run fluids and give people treatment. So she removed everything. She says, I don't want patients on the corridor. We're not going
No,
to have that.
we're not going down that
But it
route.
takes a very strong leader to do that.
Yeah, when you're desperate and you're under
Yeah.
pressure, yeah.
Yeah, it takes
Yeah.
a very strong leader to do that, to say, look, how are we going to manage this so that, because actually you're putting not only patients at risk, you're also putting staff at risk. If you have patients on the corridor in an A&E department, if you have people, ambulances dropping patients in A&E without handing
Yeah.
over because they need to go to another job.
The risk assessment would
Yeah,
be off the charts, wouldn't
yeah.
it? Yeah. Yeah. Excellent. So just quickly then, as we wrap
Mm,
today's session up, maybe if you give us your top sort of 5 key takeaways
mm,
across the 2 days. I know we probably touched on some of them already today,
mm.
but if you could give the listeners the top 5, I think that would be great. And then obviously, I'm sure we'll do another one this time next year when we go to the one in Telford.
Definitely, yeah. So the top one really is culture and leadership.
Yeah.
To sort of say, leaders, we need brave leaders representing all staff groups. There are many different professions in the NHS, not just nurses and doctors, right? So brave leadership that builds a culture which is conducive to patient safety. So you can't have patient safety without that foundation. Then the second one is governance. To say the board, that is running an NHS trust, and even the wider sort of framework of leadership in healthcare. How do we link culture with risk and learning as well? Remember, we don't want just statutory mandatory training for people. We want actually people to be educated in newer ways of working, and how also they deal with challenges that they face. Then the patient voice as well. I was really pleased that there were a lot of patient representatives and advocates.
Mm,
So patient voice is non-negotiable. It needs to be heard very loudly, and the boards as well. We need patient representatives on boards,
mm.
representing the interests of
Representing
patients.
patient
Yeah.
service users, yeah.
Then the fourth one is innovation and AI, because we have to now say innovation and AI. You can't just say innovation, because AI is almost like AI is bigger than any other innovation now.
Yeah.
It must serve the people, not replace them.
Mm.
It must be a co-pilot to a
Yeah.
nurse or a doctor or a care worker, not replace them,
Yeah.
right? And then when you look at safety, you're looking at a wider framework which requires system-wide accountability, rather than sometimes you feel like some organizations have disproportionately more power than others,
Mm.
right? But when things fail, it's the people at the front line that are blamed. I'll never
Yeah.
forget David Cameron when he did a speech about mid staffs in Parliament. And flanked by George Osborne, Nick Clegg. He was saying, um, I have written to the General Medical Council and the Nursing and Midwifery Council, asking them why no one has been struck off. And I think that's the first thing we think about. To say there's been a scandal at an NHS trust, people need to be struck off. People
Yeah.
need to be shamed and humiliated.
Yeah.
I think
And
that
lose their
that sort
livelihood.
of
Yeah.
thinking is long gone. We need to, because even staff themselves, I'll never forget, for example, patients that died on my shifts, right?
Mm.
There were not many of them, but the ones I remember quite a lot of them, right?
Mm.
And you remember their cases, you remember what was wrong with them, you remember talking to their families. Yes, I may make a mistake when I'm doing my shift, but actually, the first thing that a leader thinks about is to strike me off. That's the wrong attitude.
And it doesn't
And
put much confidence
exactly,
in the member of staff
exactly.
either.
And I'm
Yeah.
glad that we've moved from that.
That
And I think a
shift.
lot of
Yeah.
the conversations now around psychological safety, which again is the risk of being overused. If we put it there somewhere, then if it's there, people know that we have it. But
Mm.
actually, do we practice it? To say,
Yeah.
can people really come forward if they have concerns? Can people really come forward if they make a mistake? What is the first thing that we do when we hear that somebody is not happy with our service? We go into defensive mode, or do
Mm.
we talk to them and listen to them and try to help them, try to understand actually what went wrong and how can it inform practice so that it never happens to anyone, but also so that we talk about restorative justice. So I was really pleased to hear a lot of good things that are happening in the NHS, in the wider health and care system. But it's important conversations, and I'm really pleased that I managed to go. It's
Mm.
one of those things actually that you nearly don't sign up for, um, and I'm glad that I did.
Yeah. No,
Yeah,
definitely.
mm,
A lot of benefits for hopefully the
mm,
listeners, but also us as a business.
yeah,
Because it's always important to keep in touch with, like you say, what's going on, what are the big conversations.
yeah,
Yes, you can look at news stories and so on, but again, politicians involved, journalists, there can be agendas. But if you go to actually these sort of things, I think you get more of a honest reflection
mm,
of actually what is going on. And
mm,
particularly some of the leaders of those big organizations, CQC,
mm,
NHS England. Like you say, I know there was no government official there, but the real sort of key people, let's say, show up for these sort of events.
mm.
And it's a national event, isn't it? You got people from all
Mm.
over the UK attending.
Definitely, and also you learn from each other as well, because
Mm,
even when you look at accident investigations,
mm,
right? For example, the airlines. We've learned so much from the aviation
mm.
industry
Yeah,
about accident
they've
prevention
set the bar very high.
and
Yeah.
accident investigations,
Mm,
but also fire service, also the
mm,
police.
mm,
Also, there's so many even health and safety. People. We had Loughborough University there because they deliver some training that was funded by NHS England for patient safety. And I know some people, some colleagues that have done that training, and they found it really useful. How do you investigate accidents without, you know, treating people like numbers, without dehumanizing people? How do you separate the facts, and learn from them? What
mm,
is the purpose of accident investigation, for example? That's why the new framework actually is better because it looks at several factors rather than just who is to blame, you know.
yeah.
Because I know, I used to do root cause analysis for patients that have had a venous thromboembolism. So if somebody has a VTE, we call it VTE audit, where you're looking at all the patients that have clot, so then their leg or in their lung, within 90 days of an admission to hospital. And quite often you'd see within the first few pages, you know exactly what went wrong. And it was constantly the same problems. I'm talking about, I
Mm,
did this job in 2009, 2011. And guess what? We're still talking about it in National Patient Safety Congress 2025.
Mm.
Still, tens of thousands of people are dying every day from preventable blood clots.
But we're still talking about it, yeah. So I think,
Yeah.
like you
Mm,
said in your sort of outro there, the
mm.
action on the back of these
Exactly.
conversations is
Exactly.
what is how people will really be measured.
Mm,
Like we're talking about sample sizes and
yeah.
new regimes coming in, new people leading and facing these organizations. So
Yeah.
yeah, hopefully over time things will improve. So yeah, thanks a lot for today, Richard. Some very interesting conversations. As Richard hinted throughout a lot of some of the themes we looked at today, as a compliance solutions business, we will be looking at patient safety as a topic and seeing how we can help some of you businesses, particularly you smaller, medium enterprises that don't necessarily have unlimited budgets, lots and lots of resources, lots and lots of people even to monitor and track these things. We will try and come up with some solutions. We already have some readily available tools within ComplyPlus, but also some
Mm,
free things that we've developed, particularly this year, including things like training matrices, reporting dashboards, and so on. But I think the patient safety angle we've discussed today, there's a lot of other things we need to start considering, and a lot of other things we can hopefully help you all with. So, like I say, we'll be back here again in a couple of days' time for another episode. But like I say, keep an eye out on our LinkedIn and our website for some more updates on patient safety and some of the tools we're going to be looking at developing in the latter part of 2025 going into 2026. Thank you
yeah.
very much.
Thank you very much. See you next time.